to just formally welcome you to this morning's UUCD Forums. We are joined this morning by the Harm Reduction Sisters. Harm Reduction Sisters is composed of a dedicated team of volunteers, staff, and community members who collectively create a network of harm reduction education, access, and resource sharing across northern Minnesota. And we are joined today by staff members Kathy Hermes and Sue Purchase for an overview on their harm reduction services, including distribution of sterile injection supplies, overdose education, and naloxone to communities in northern Minnesota. We have some wonderful handouts even. And so at this point, please join me in giving a hearty welcome. And the floor is yours. Thank you so much for being here, Kathy and Sue.
Thank you, Brett. So my name's Kathy. I use she, they pronouns. I am very new to harm reduction as it relates to addressing drug use. I've been with Harm Reduction Sisters for less than a year. Prior to that, I was doing harm reductive work, I think, with LGBTQIA2S plus youth. And so as I climb the learning curve related to drug use harm reduction, I'm humbled, I'm amazed, and I'm heartbroken to Sue's my harm reduction sensei, so I'm going to pass it off to Sue to introduce herself.
Thank you, Kathy. Good morning. I'm Sue Purchase. I'd like to talk about harm reduction, and there's a lot to talk about, and I've been working in it for 30 years. And I always start by talking about how I was born and raised in northern Minnesota, in a place that I thought I was from and never to return to again. It wasn't exactly a pleasant experience, and when I turned 18, I was gone. But the important part is that how I came to harm reduction and to be able to work in harm reduction for 30 years is I just joke about how I parlayed my drug use into a really good job, which is really true. And that's how people come to harm reduction, really, in many ways, is through lived experience. And, like my lived experience, I was born at St. Luke's and I grew up in Cloquet, and I grew up in a household that was filled with domestic violence and how alienating and isolating and difficult it was as a kid to grow up in that environment, and how drugs and alcohol became a coping mechanism for sure by 12, smoking cigarettes at 9, and all the behaviors that happen and change over time, and starting as a kid and adolescence, and then into adulthood. And so when I say that I parlayed my drug use into a really good job, I did. But between, how I got there, there was a lot of different, experiences that really, you learn a lot and pay some high prices for behaviors. And my introduction to harm reduction, I think about it, and I was a single parent with 2 little kids, and I had a dead husband, and trying to figure out how I was going to make it and wanting to do something different, and I had returned to Minnesota, to Minneapolis, and when I was introduced to the idea of harm reduction, in the early 90s, maybe even late 80s, it had more to do with alcohol. I just thought, well, that is the craziest thing I'd ever heard. How do you reduce the use, right? And how do you reduce the harm? I always thought it was an all or nothing proposition, but I had a lot to learn. And so, you know, like coming full circle is what brought me back to northern Minnesota, because never say never, right? You don't know what's gonna happen. And so I'm here to well, really come full circle, make peace with my past and provide services in a region that is so desperate for them.
And I'm gonna add that Sue has done harm reduction work on the East Coast, the West Coast, and right in the center of the country in Colorado, and probably places in between, so a wealth of experience. So I'm gonna speak a little bit about our syringe services program that operates out of the Damiano building, and then Sue will talk about all kinds of other things that we do beyond what goes on in the Damiano building. I will be reading the harm reduction principles to you, and Sue will likely riff on some of those principles because she's got this encyclopedic and experiential wisdom that allows her to speak extemporaneously and impactfully on policy type stuff. And then if time allows, we can talk a bit about drug trends and drug testing, specifically as it applies to our community. Also wound management, that's a rising concern and need. Potentially talking about recent legislation, because Minnesota's kind of exceptional across the country in terms of our progressivism related to harm reduction. Maybe you could talk a little bit about safe injecting sites and give you some ideas about what you can do to be a harm reductionist yourself as time allows. So with that, I'll just share a little bit about our location in the Damiano Center down on 4th Street. We've got kind of a room and a half.
Yeah.
We're a sweet town. And that includes an expansion. We were just one room with a handful of humans and a really bustling syringe exchange program going on. And now we've got our syringe services program in that little half room, or maybe third room. I'm not sure if it's as big as a half room. And so Monday, Wednesday, Friday from 10 to 3, guests are welcome to come in to get harm reductive supplies, get information, get advice, maybe get the opportunity to take care of their wounds in a space that's safe where they're not going to get hustled out, and all kinds of other things that go down in that little space because our syringe services workers are trusted, recognized members of the community that we see coming through our doors. So if you were to come in, there's a bunch of shelves and we've got thousands of syringes, clean syringes. We have the supplies to utilize those syringes, things called cookers, there's cottons, there's tourniquets or ties, there's sterile water in little plastic ampules. We have a lot of safer smoking supplies, that's largely glassware. And if we had the time, we could talk about the harm reductive shift between injection and smoking. We think we're seeing a positive shift if only we had enough cash to keep that choice alive for people to get glassware every time they wanted it when they walk through our doors. We have wound care kits, we have hygiene kits, we have, let's see, I'm trying to, fentanyl testing kits. We've got some xylazine testing kits, but we're keeping them on the down low until we are able to practice with them ourselves. And then there's a variety of other things that might be available when folks come in, just depending upon donations or how well Sue's been able to hustle for some freebies. And as a newbie, I'm even learning the freebie hustle, and I can drag stuff in. Oh, and I forgot naloxone. One of the most important things that we distribute. We've got some here if you want some on that end of the table. So yeah, it's a bustling place, 10 to 3, Monday, Wednesday, Friday. Sloan, Delaney, and Shayna are exceptional outreachers and communicators and trust builders and amazing, inspirational and heartbreaking situations play out in that space pretty much every day that we're open. And so, Sue, if you want to share other stuff.
I would say that the SSP didn't start at the Damiano Center. It started on May Day 2019, and I had returned to Duluth in 2018, and I understood that there was a gap in services for people who use drugs, which isn't a surprise, right? But so it started with mobile delivery, and I thought that there would be a slow ramp up for services, but then COVID happened, and like really, it was absolutely insane. And every like I had no real concept of how much drug use was happening in northern Minnesota, and I still am constantly shocked and surprised. So it really started off with me delivering syringes, and through word of mouth, like that just grew. And so like that's how we, mail order, delivery, secondary exchange, but really doing whatever it took to get syringes, new, sterile, unused syringes into the hands of people that needed them the most with naloxone.
Thanks, Sue. So you're gonna get a little harm reduction 101 here. So I'm gonna read to you the principles of harm reduction as put forward by the National Harm Reduction Council. And Sue might have a little bit more to say. So principle number 1, harm reduction accepts for better or worse that licit and illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. Got anything to say?
Well, it just says it all. It's a fact of life. Legal, illegal, doesn't matter. People are using drugs. We all use them in some sort of way, whether we recognize it or not. And I think that we are here to help and support people.
And then principle number 2, understands that drug use is a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence, and also acknowledges that some ways of using drugs are clearly safer than others.
Yeah, I think that is all really true.
The third principle establishes quality of individual and community life and well-being, not necessarily cessation of all drug use, as the criteria for successful interventions and policies.
It really, it's a public health, social justice model that really respects the dignity of all human beings, no matter where they're at on the continuum of use.
Do you want to say anything about Hazleton?
Hazleton is the mothership in Minnesota and the Minnesota model, and that abstinence is the gold standard, right? And everybody wants the gold standard, but not everybody has access to it. And so even, if people, eventually can get there, we want to keep people safe and alive until they can choose to do something different, if they choose to do something different. A lot of people live with tremendous trauma and just trying to cope with living in their body on a daily basis. So we're here to help people with that process.
The fourth principle, harm reduction, calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. Anything to add?
I think it says it all.
Okay. The fifth principle ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them.
That is the crux of harm reduction. You have to involve people who have lived experience, who know what it's like, and not to say that everybody's experience is the same, but you bring a wealth of knowledge and empathy and care to people. when you've been there, right? When you've traveled some really hard roads and not judging somebody else.
The sixth principle, it affirms that people who use drugs themselves as the primary agents of reducing the harms of their drug use, and seeks to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use.
We do that every single day.
And I'll just add that this is one of the things that struck me the most, shifting from queer youth support to what I'm presently doing, is the inventiveness in terms of solving crisis level problems like in the moment or that day or that weekend, and sharing it quickly with other people so that the harm reductive impacts of their quickly constructed solution does not rest just with them. There's a lot of power and knowledge and ingenuity and entrepreneurship among our drug using friends and neighbors out there in our community. And we should tap it better. Sue's cooking up what are you calling it? A user's
A drug user union. That's what I want to do. And so really, like, we have to have people that are empowered to make change and have education and understanding and be able to share it with their network of people, because really we're in a crisis up here. It is a public health crisis of catastrophic proportions. And I don't know how people can't know and understand that. And you have to respond, like it's an imperative. St. Louis County and so much more beyond that, but like this is the worst county in the state. And you know that Minnesota has the worst disparities in the country. So as we like to pat ourselves on the back about what a great state Minnesota is, it is racist. And it ignores people that are so desperate for care and help. And maybe my message would be a little bit different if I hadn't done all of this through COVID and saw the just people didn't fucking care. Like really, like people were so scared and meeting people that didn't know me. They may have texted me, they may have had a friend that used the services, but people would say, Sue, what do we do? Are we gonna die? It's COVID, you know, like there's no place for people to go. There's no shelter. The chum is full, or maybe the chum is deciding who can come in and who can't. And people are supposed to be social distancing and hand washing and having a mask. And we failed them miserably. And so, you know, people that weren't doing drugs started doing drugs again. Where is the care? Where is the humanity? Where is the public health? And public health is for the public, not just for a select few that we deem worthy. Like, who are we as a society and what are we gonna do? We gotta step it up.
So to reinforce some of what Sue just said, the seventh principle recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. I think you said enough on that topic.
I do too.
And then the final principle, the eighth one, Harm reduction does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. And I think Sue will talk a little bit about our challenge with drug trends and needs for drug testing. But before she does that, I'm going to share what harm reduction is not. It is not rigid. It is not forced. It is not top down. It is not abstinence only. It is not judgmental. It is not moralistic. It is not based on punishment. And finally, it is not based on the idea that people who use drugs are bad people. So Sue, did you want to touch a bit on drug trends and drug testing and what we're seeing in moderately sized Duluth and beyond?
So the drug trends in Duluth and I would say all of Minnesota, but certainly up in this region, you know, people used to think that they were doing heroin or meth, fast or slow, sometimes a mix, used to be called a speedball or a goofball. Now, there's no heroin. Like old school heroin is just gone. And there's fentanyl, which in and of itself is, it doesn't have the long half-life that heroin had, so there's more frequent injecting, you know, like the effect doesn't last as long. So there's that, and then there's xylazine with fentanyl in what people perceive to be heroin. And xylazine is a veterinary tranquilizer. It's some form, it's called a kappa opiate, which I don't understand a whole lot about, but I'm learning. And fentanyl, like you have to administer naloxone, right, to reverse an overdose. But with the addition of the xylazine with the fentanyl, it makes overdose reversal almost, I wouldn't say impossible, it's much more complicated in that it requires multiple doses of naloxone. And then, you know, some rescue breathing, trying to keep people alive, right? And so in situations where you're administering naloxone, administering some rescue breathing, trying to bring people out of a complicated overdose situation. And for some people, that involves calling 911. You know, we have a Good Samaritan law in the state, Steve's Law, but it doesn't necessarily go far enough to protect enough people or protect people well enough that they're inclined to call. So we've got a drug supply that is so complicated, so dangerous. Some people might say, you know, like it's always been dangerous, right? But there was a level of understanding and knowledge that, well, that things were just better than what they are right now. And so like with multiple overdoses, multiple deaths, I think we had 4 fatalities just last weekend. And then there's been at least 2 that I know of since then. I don't know how many before that. I've gotten some messages in the last few days that says the overdose death count in Duluth for this year is at about 37 or 38. But so like it really, like it's just complicated and hard, right? And so like that access to resources, to treatment, to you know, like detox, just services to help people reduce the use or reduce the harm, or maybe enter a treatment program. I don't know what else to say.
I'll shift directions a little bit and talk about wound care as it relates to what's going on in Duluth and the country for that matter. People make the informed choice to not go to Essentia or St. Luke's or the associated clinics because they're informed by their experience of racist response, erasure, rudeness, just being ignored, stigma-induced stink eye, just basic rejection, just really negative vibes when they go to our larger healthcare facilities. So since they've been informed that way by their personal experience, they seek out other opportunities to take care of wounds. Run-of-the-mill abscesses. And I say run-of-the-mill because like xylazine, that animal tranquilizer is creating wounds that are they're baffling. They're leading to amputations for some people.
Flesh eating.
Yep. Because xylazine is a part of that really rapid flux in the drug using landscape, physicians haven't been trained to respond to it, and so you've got these devoted street nurses, especially out in Philadelphia right now, learning how to respond to these wounds. And so people in our community who have been informed by their negative experiences at Essentia St. Luke's, they're looking for some place to go. Sometimes it's sitting in a gas station bathroom trying to dress your wounds, and someone's pounding on the door trying to kick you out before you're done. Sometimes they find us. We'll give them we give them supplies when we have them. We give out wound care kits when we got the full-blown kit, but we often run out, so we give out the components that we have. We let them show us their wounds. We're taking photos of wounds and sending them to wound care nurses who know better than us, because we can't treat them. We're not qualified. We could just give them supplies and a place to sit quietly and uninterrupted to do their own care. Rural AIDS Action Network is another location where they can get wound care kits, CHUM, when the UMD residents are on site, and they're providing some basic health care. But we're really in this dangerous period of time where we're pretty convinced that some of the wounds we're seeing are xylazine related, and they are cryptic. They don't necessarily show up where an injection was done. They look very innocuous to start out, and then before you know it, it looks like full-blown flesh-eating disease. And we've got limited time to help people respond. And it's really hard to convince them to go to a formal healthcare provider. But in some instances, they really need to. They've got deep set infections and are potentially going to lose a limb if they don't make that choice along the way. So Sue's concocted what she's calling a wound care kiosk in the corner of our bigger room that also doubles as our main office. And
381 square feet. And we've got a little corner with I guess it's a stainless steel table and a rubber mat underneath, and we're just getting it set up so that we want to be able to provide wound care kits for people like grab and go, but for people who might want to tend to their wounds a little bit, and maybe with some limited assistance. I am not a nurse. They would have a place to take care of and dress their wounds. Like it is, we just have to respond to an unmet need. And so we just are doing it the best we can.
which makes me think if you want to help us out, helping us with getting the components of wound care kits. We've got a fantastic recipe put together by Dr. Broughton at Duluth Family Medicine. But we just don't have all the parts to put in those Ziploc bags to get out to people. And I just remembered something else we do that we haven't mentioned yet. We do HIV, hepatitis C, and syphilis testing, especially important because there's an HIV and syphilis outbreak in the Duluth area now.
Yeah. Can I just talk about politics for a second? I think we should talk about politics, like really like around syringe services, and this is so important, you know, and like the state of Minnesota fully supports syringe services and smoking supplies. Like we are able to apply, well, we get direct funding through the state to pay for them. Federally, there's a ban, and there's been a ban on syringes for, well, since 1988 in the Helms Amendment. And so where the science was certified that syringe services are an effective public health intervention, does not increase drug use, does not start drug use, but it was Mr. Clinton put the onus back on the states if they wanted to fund it, but federally it wasn't going to happen. And so the state of Minnesota responded right away. At that time, I had the first harm reduction program in the state of Minnesota, and it started in 1996 in Minneapolis. And so like they funded things. Federally, it doesn't happen. The ban was lifted for about 2 years during the Obama administration, but it's been firmly back in place ever since. So we've got a federal government that's not exactly helpful.
Do you want to just keep rolling on politics business? Like how we were criminals before August 1st and now we're not?
Yeah, we were criminals and have been, well, I've been a criminal for a long time, I would say, in that, you know, like that it was never, in the state of Minnesota where they were at with syringe services, originally it was like it was legal if you had a research component attached to it. But it's been a gray area forever. In 1998, they changed pharmacy access laws for syringes where in pharmacies that chose to participate, it was optional, they could sell 10 or fewer syringes without any questions to people who use drugs. That didn't exactly go as planned, but there's been some limited pharmacy access all of these years. And then well, just this past August 1st, and I think in large part related to there's a HIV outbreak up here, which a lot of people think HIV went away, but it didn't. But so there's been some legislative changes that really allow for the legality of harm reduction services for SSP, syringe service programs, that they will be funded, that there is all drug paraphernalia has been decriminalized. Pharmacy access of syringes, that limitation of 10 has been lifted. What else within there's just a whole plethora of legislation that is going to make including overdose prevention centers in the state of Minnesota legal. I feel like I'm forgetting something. I don't remember exactly what it is, but really like it gives like harm reduction best practices. It's legal. We can do this work and without fear of prosecution and arrest. And so like it is the most effective public health measure there's ever been. And I would say that in the state of Minnesota has always been really supportive of the work of harm reduction, my work. But other places in the country, I've had colleagues whose organizations have been firebombed. I mean, like the extent of well, I don't even know what word I want to use. You know, like we're here to do good. We're here to keep people alive. We're here to provide a service that people find so distasteful. And harm reduction is really built on any positive change as people choose to define it for themselves. And if you just think about that, in any context, whether, you smoke cigarettes or maybe you overeat, maybe you have heart disease, and maybe you like steak and you've been to the doctor and he says, one more steak and you're gonna die. And, you should be taking care of yourself and no ice cream for dessert, but if you have a heart attack, even after those warnings, chances are that doc is still gonna care for you. But what if you have the disease of addiction, right? And you've been told that you need to get your act together, and if you didn't do it fast enough or well enough or good enough for the powers that be, we're gonna quite literally kick you to the curb and say that you don't matter. And then if you die of an overdose, so be it. Who cares? You were warned. You were supposed to go to treatment. You were supposed to sober up. You're supposed to seek resources. How easy is it to just say no? We could thank Nancy Reagan a little bit too.
So I think time for questions. Yeah.
Hi, thank you for your presentation.
Just wait while here, I'll pass you this.
Thank you. Appreciate your talk today. Can you talk a little bit about overdose reduction centers and what those are, and are those coming to St. Louis County?
So oftentimes, they started off being called safe injection facilities, and then they morphed to overdose prevention centers, and New York City currently has 2. There's been other places in the country that have tried to open an OPC and haven't been successful. With the legislation in Minnesota, yes, Minnesota is ramping up to have an OPC center, maybe 2, maybe I think there's a lot of unknowns around it. It's written into the legislation, but what that's actually going to look like, we don't really know yet. But yes, I would like to see one in St. Louis County. And it is, I think it's where, people could get up in arms about an OPC. If you're familiar at all with what's going on in New York, an OPC in New York and an OPC in Duluth would look dramatically different. And what I envision here is that oftentimes in a drop-in center, a harm reduction center, people want to use, they want to use on site in the bathroom. And it's happened. And what I envision is that, maybe there's something like an enhanced program where people can choose to use on site under supervision with some care. And but we don't know what that model will look like yet, but it's definitely a conversation being had.
You mentioned never use alone as a bridging service.
Yeah, and there's a nationwide number, Never Use Alone. It's a 1-800 number where when you call that number, you are going to get a person who will stay on the phone with you while you use and through your experience. And if you go out, if you overdose, they will call 911.
There was a question in the third row back there.
Perfect, and then we'll go to Meredith after this. Thank you so much, Sue and Kathy, for this.
I've read that 75% of women who are drug addicts have been sexually abused as younger women. One is, do you think that's true? And 2, if you know that, what can be done to help that?
That's a really good question. And it used to be talked about, and I haven't seen recent statistics or anything, but that, you know, like 85 to 90% of women who were in a drug treatment program had been sexually assaulted at least once during their lifetime. So, you know, like if we're talking about trauma, right, and that people are self-medicating, you know, and you're self-medicating trauma. And oftentimes trauma starts well before the age of 5. And, you know, like I would say that, well, I hear a lot of stories, and oftentimes what I call them is unspeakable horror stories, you know, like they're just, people talk about how they didn't want to use drugs. And always people started off by, well, you know, Sue, I'm going to go to treatment. I'm going to do this. I didn't want to do this, you know, all of this. But I had a one young woman talk about how her first time doing heroin was at 9 when she was injected by her mother so the mother's boyfriend could have sex with her and she wouldn't complain. So that is like, that sets people up for failure, right? In grand style. Can you imagine being 9 after that? Let's go to the playground. Let's have sleepovers, you know? Let's be an A student. Let's do really well in school and all of the things that happen and people just step on you.
I'm going to soapbox a little bit in response to your question and draw from my previous work. We need to address the binary supremacies around holding firm to masculinity and femininity standards and no longer normalize men abusing women and girls.
Yes. Yeah, Meredith.
But I know also that you want to share a little bit about this, so let's have Meredith's question and then we'll make sure to save time for this too.
This might be a little segue into that actually. So my teenager, Charlie, a senior at Harbor City, was recently in a health class and they showed the kids how to do CPR and stuff. And then Charlie was telling us about this afterwards and said, and they also mentioned test strips, but they said, you know, basically abstinence first, and they didn't show us the strips. They didn't tell us how to get them. They didn't tell us how to use them, and the same with Narcan. And so I'm wondering about whether, you know, should we have our kids whose friends may be using, should we have, you know, like have them set up so that even if they're not using themselves, they can help out their friends. And maybe that's what this table will help to do.
Yep, I see a gigantic yes. What do you say to that, Sue?
Oh, without a doubt. Without a doubt. You know, like absolutely. And like people have to know kids are dying. Their classmates are dying. Their siblings are dying. The youngest harm reduction sister that I know of that has been trained is 9. And is distasteful and I don't know, illusion shattering as that might be. Everybody needs to know how to use test strips. They need to know how to use naloxone. They need to know the difference between Narcan and naloxone. Narcan is a trade name for nasal Narcan. And we have injectable. I would say that Harm Reduction Sisters has never been funded to, we've never had a naloxone budget, but we've always got naloxone. And we are, there's an organization in New York called Next Distro. And they operate a hub and spoke model, and Minnesota is Harm Reduction Sisters is the Minnesota affiliate, like we're one of the spokes. And so people can go online to next distro and request naloxone being sent to them through the mail, and it'll come from Harm Reduction Sisters. And so we mail naloxone all over the state, no questions asked. We serve youth, no questions asked.
And I'll add, children are saving their friends, children are saving their family members. And they're figuring out ways to get to naloxone, even though the adults in their schools and other layers of adult influence in their lives they're not making it accessible, but they're getting their hands on it and they're saving people sometimes as kids. So the stuff we have, we've got some menu cards with our services. There is injectable naloxone here. This happens to be our next distro version, so it's got the next distro pamphlets on them. You can always come and get a whole bunch more from us, or we'll drop it off, or we'll mail it. These are fentanyl test strip kits. So if you want to pick one of these up, and like I mentioned earlier, we do have xylazine test strip kits, but we're sitting on them for the time being until we're confident about how they can be used. We've got little CPR shields. They're little keychain variety. So important with xylazine in the mix, where depression of breathing function is, one of the main things that's happening in people's bodies. Naloxone isn't going to work for the xylazine. Sometimes, as Sue had mentioned earlier, the rescue breathing is the more important element, but it's very complex because you don't know for sure. So you kind of got to do both. And then if you want to take matters into your own hands and you want to do a little bit of helping the whole harm reduction movement by picking up syringes, that's one of the main things that's brought up when there's opposition to harm reduction programming. Here's what you need: some kind of thick plastic opaque container, kitty litter container in this case, some gloves if it's warm enough not to have full-blown mittens on, and then a pickup device. I have my kind of bougie tongs. You don't need fancy ones like this. You can just get those little plastic ones. Just something to allow you to safely pick up syringes or syringe parts. You can also get the kind that for everywhere. You don't have to bend over. We got some of those for our little syringe pickup outings that we do in the Central Hillside neighborhoods.
I know we're almost at time, and so I do want to spend one last question actually, and I'll check to make sure online we don't have any other ones. But then after this, do feel free to continue to interact too before the service if you have any other ongoing questions for Sue and Kathy. How can we best support you as a congregation? That's kind of how I want to end it for another minute or two. What would you recommend for next steps for all of us listening in today and those on the recording later?
Before Sue responds, I'll just say normalize harm reduction in your conversation with friends, family, and anybody you cross paths with when the opportunity to talk about harm reduction comes up, and maybe create those opportunities.
I think that would be my answer as well, and really think about, well, syringe use is a fact of life, whether we like it or not, it just is. And so like I think really normalizing those conversations, and where you can have them at the dinner table. It's one of those complicated things, right? Where people wouldn't sit down at dinner and say, well, I'm shooting dope now, and it's gonna just be pleasant, right? But like really have to have real conversations about drug use, because that's what's happening, and we want to save lives, and we don't want the trauma to continue. With every death, it just gets harder and harder and harder. So, dignity and respect and any positive change as people choose to define it for themselves, and we can practice harm reduction as one large community in Minnesota.
And I'd add, if you want to send a little cash our way, our tobacco fund, we give away cigarettes to folks as a way to welcome them in, and also it's a harm reductive practice too. But we're boom and bust. We run out of the tobacco really fast, and then people don't come for a while because we're out of that. And then we have it again for a while. So just kind of a little slush fund for those kinds of expenses. And it would help us with gathering hygiene kits and maybe some of the harm reduction supplies that we are lacking, so we can't put the full-blown kits together right now.
I would definitely say hygiene kits, some people call them menstrual products, but like shampoo, menstrual products, anything, some soap and shampoo, those small things, like people need that. And I think that, just like with the cigarettes, like it's surprising to people. And they're getting to know us a little bit more. And so like it just brings people in the door that we are just really a community-based organization for people that are generally forgot by everybody else. Thank you.
Well, on that note, please join me in giving a huge round of applause. Thank you for your services to the. It has been so educational. Please do come up and grab any of the additional helpful materials that they brought, and join us next Sunday. We'll have WLSSD come in and talk about composting and the new on-site that's available here for UUCD, as well as what you can do at home. Awkward, obviously, transition, but also for those listening in or listening in later, it's harmreductionsisters.org is the website to follow up after today. So again, thank you so much.